Okay, so I get to welcome everyone. And thank everyone for their patience. I'm so sorry about this little hiccup that we've got. But my name's Louise and I'm the Vice President of Scleroderma Victoria. And I would like to give a shout out. Oh, sorry, I've got to work out how to get my screen up. Wow, this is challenging. Here we go. Give a shout out to our committee members here today. So welcome to our monthly virtual education session, and it's lovely to see so many familiar faces and some new ones too. So these virtual education sessions are run by the committee members of Scleroderma Victoria, and we run these sessions the second Saturday each month. We offer the sessions free of charge due to a grant we receive, and for that we would like to thank the wonderful Scleroderma Victoria Committee who put in time and effort to apply for these grants. Now we've got a couple of rules. So while the presentation's on, if you could turn your microphone off, and we will have question time at the end. And you can see there's the chat, so pop any questions in there and we'll get to it. And I'm assuming that turning off on Zoom is the same as it is in Google Meet. There should be a microphone that you can click on and off to change that microphone. So today we're going to talk a little bit about the National Sunflower Day, so shine like a sunflower. Then we've got our guest speaker talking about wound and preventative care. And then as always, we will have our questions at the end. So last year we moved our Shine Like a Sunflower to the Shine Like a Sunflower Day to the 6th of March to National Sunflower Day. Previously, it had coincided with World Scleroderma Day, which is in June, and that's far too cold for anyone living with scleroderma in the Southern Hemisphere to be able to participate as fully as they'd like to. So by moving it, it's a more inclusive date and everyone can participate. Plus, it's the season for sunflowers to bloom here in Australia, which is fitting because the sunflower is the scleroderma emblem. Sorry, I'm beeping a little bit. I'm just going to check emails and see. Oh my goodness, this is hilarious. Oh, people can't load Zoom. All right, I'll go into recovery mode in a minute. So National Sunflower Day will raise awareness for scleroderma and it occurs on March 6th. And we're lighting up Australia with a vibrant yellow glow for our annual Shine Like a Sunflower campaign. And we're encouraging people to wear yellow. We're also asking people to donate anything they can to help raise essential funds dedicated to scleroderma specialist nurses and scleroderma research. In 2024, we had over 60 locations lit in yellow across Australia, and we're looking at doing much better than that in 2025. So what we're asking you to do is to light up a monument, landmark, or a building near you. So have you seen a landmark lit up in your area in the past? Or is there a landmark near you think could be lit up? If so, can you reach out to these places to find out what's involved and get the building or the landmark lit up for our Shine Like a Sunflower event next year? As you can imagine, this takes a lot of work to pull together an event like this, and all assistance is appreciated. So we are such an amazing community, and working together, we can really blow up next year's event. So any leads or contacts you may have or any assistance you can give, please let us know and email our hello@sclerodermaaustralia.com.au email. The raised funds go to dedicated specialist nurses who having an expert to talk to not only helps people living with scleroderma to better manage their condition, it also decreases feelings of isolation and improves our mental health. Support is crucial with a rare disease like scleroderma, and we're proud to be raising funds to pay for specialist nurses who provide much needed support for our nearly 6,000 people across the country living with scleroderma. So reach out to your community and see where you can light up. Now, this month is a bit of a special month because we actually have 2 virtual education sessions. So we have another education session this month with It's called Healthy Discussions, Empowering People to Have a Say in Their Health Decisions. So everyone has the right to make their own decisions and to receive support they need to do so. So this includes adults with disabilities. The Healthy Discussions project aims to improve communication between people with disability and health practitioners and is informed by voices of people living with the experience of disability. So what they offer, they have developed an interactive presentation designed to help participants explore important aspects of effective communication in healthcare consultations. They understand the principles and practicalities of supported decision making and appreciate their responsibilities as healthcare providers, and they hear the voices of people with disability. So this information session aims to provide participants with practical communication and engagement skills to increase their confidence in supporting patients with disability to make informed decisions. Currently, they're presenting to Victorian hospitals, health groups, and advocacy groups. And they're very keen to implement this training into all Victorian healthcare networks, PHUs, and people living with disability. So this will assist in building the capability of the community and the health workforce to understand and respond to the different needs of people with disability. So you can register for this event through Eventbrite. Remember to follow Scleroderma Victoria and Scleroderma Australia on Eventbrite to keep up to date with all our events that are registered through this platform. So that is on October 24th from 10:30 to 11:30. So we know it's during the day thing, so we hope we can have plenty of people who will join us on that day. Okay. Now it gives me great pleasure to introduce Dr. Tracy Frech, who is the Division Director of Rheumatology at Vanderbilt University Medical Center. Her primary goal in research and clinical care is early diagnosis and effective healthcare delivery to systemic sclerosis patient population. Under her scleroderma clinic directorship, the University of Utah and Vanderbilt University Medical Center were recognized by the National Scleroderma Foundation for excellence in care. Dr. Frech is also interested in improving early diagnosis and vascular-based treatments. Her specific research interest is to better understand the natural history in scleroderma. To that end, through collaborations with the Prospective Registry of Early Systemic Sclerosis, the Inception Systemic Sclerosis Cohort, and the Utah Vascular Research Laboratory, and the Collective National Quality and Efficacy Registry. She works for improvements in diagnosis and treatment of scleroderma through meticulous patient phenotyping. So it gives me great pleasure to welcome you today, Dr. Frech. Now, how do I stop sharing? Here we go. I got there. Thank you very much. Now, Dr. Tracy has got her screen up. This is fantastic.
All right, and perfect. So I think we did a fine baton pass there. So happy to be here. Really appreciate the introduction and invitation, and especially your patience, as I was worried it was my end that I couldn't connect. So as I apologize for the emails there, as you were trying to get everything connected, but just absolutely thrilled to be here. And I'm going to talk today a little bit about the challenges and opportunities for assessment of scleroderma digital vasculopathy. And I purposely use that term of digital vasculopathy rather than digital ulcers or Raynaud's, because I think we really want to think through Raynaud's and a resultant digital lesion as being on a spectrum of vasospasm. And when you hear the term vasculitis, that means inflammation of the blood vessel. And when we use the term vasculopathy in scleroderma, sometimes it becomes a little confusing because opathy means abnormality of the blood vessel. And as we'll talk about, there's a lot of different ways we can assess that and treat that phenomenon. So I have no relevant financial disclosures or conflicts of interest. I don't do anything for pharmaceutical agencies for money. I will mention some drugs, so it's important to always know if your speaker is receiving funding or money from the company, and I do not. So everything I talk about is from clinical experience. So I have three main objectives today. The first is I'd like to discuss why I think it's really important that we integrate research into clinical assessments, and that systemic sclerosis actually is the perfect disease to really discover through clinical care. It's really important that we do registry-based work and that your doctor is very in tune to what you're experiencing and how you're feeling. And I always say every good research idea I ever had came from a patient that asked me a question and challenged me to think of a better answer than this is just what we do in scleroderma. So please continue to talk to your doctors about things that you think affect your fingers. Second, we're going to talk about scleroderma digital vasculopathy diagnosis and management opportunities. And that's really important because things caught early, we do a lot better with. And so it's important to kind of go through how we assess the hand in scleroderma. And then we're going to conclude by just discussing about collaboration. And in particular, I do a lot of research and education in our renal rheumatology clinical program. So we really talk about blood pressure medications and how we optimize blood flow to the fingers. So I usually start, and perhaps this audience doesn't need any convincing, but I think systemic sclerosis really requires integrated care between all your healthcare providers. And if we really want to make the largest quality of life impact in our rheumatic diseases, systemic sclerosis is actually the most important disease to do this well. As you all know, systemic sclerosis is most common in women between the ages of 20 to 50 years of age. And that's actually why I take care of this disease. This is why I'm passionate about taking care of patients, is I often think if we do this well and we help our patients, we give the best years of a woman's life back to her. So I'm very passionate about trying to improve both quality of life and outcomes. And there are many unmet treatment needs. In the US, our only two FDA-approved treatments are for interstitial lung disease. And so I've been really passionate about leading efforts to try to get vascular drugs to the forefront for treatment of systemic sclerosis. So I'm going to tell you a little bit how our Scleroderma clinic works and why this has really helped us think through how to treat digital ulcers. So we started a program many years ago where we had two referral patterns. So we could get patients in really quickly if they just had systemic sclerosis suspected on a laboratory test. And these patients got a physical exam, capillaroscopy, and proper autoantibody testing, because there's a lot of sort of bad assays out there which had false positives. So we really try to triage patients quickly so we can make a diagnosis. And then we had another subset of patients, and these were patients that had a complication or concern for multi-organ system involvement. And as pertinent to the talk today, what I became very interested in is trying to coordinate care with wound care and occupational therapy and behavioral health to try to improve outcomes when patients had a digital ulcer. So they got, the patients that had a digital ulcer got all the same care as our quickly triaged patients, but also had some coordinated care appointments with our other subspecialists. And why that was particularly important in the program that I set up is patients were coming in a 5-state referral area, and so traveled many hours to get to the Scleroderma Center. All that to say, I think the key, if you have a digital ulcer or a wound, is having coordinated care and excellent communication between your care plan. And why this may look like, and we'll talk at the end, of how the different providers you may see may offer different assessments and laboratories to you. We really found that our ancillary services working really close, so if a wound occurred early, getting that patient seen and treated and having that wound protected really improved outcomes. And I also really want to highlight that we had a social worker who was available in the clinic who came in, and every patient talked about stress management and really ensuring that we were providing work note excuses if the environment was cold. And so I think there's a lot we can do preventatively by working with the care team. So there's some challenges for treating Raynaud's phenomenon and digital ulcers in the United States. And in particular, we don't have, if it's not FDA approved, then the patient oftentimes pays the cost of the drug. And this is particularly important if you're reading articles that come out of the United States, oftentimes guideline-based care where there's prostacyclin analogs used are not the patient population coming out of those registries. So it's really important if you're trying to understand what works or what doesn't work, what is available in that country, and how are those drugs used as ramp-up therapy. So what's the first line, second line, and third line? And in particular, if you read about about U.S.-based care, the importance of a scleroderma center, it becomes pivotal. So patients with scleroderma who are not seen in a scleroderma center oftentimes don't have any access to the drugs that are pretty standard guideline-based care protocols such as prostacyclin analogs. And we'll talk a little bit about these drugs. We also oftentimes try to do inpatient care for digital ulcers when we're unable to get a lot of outpatient care coordinated. And so if you're reading an article and they talk about a complicated digital ulcer, and the Italians talk about this a lot in their literature, a patient that's inpatient might have a very different ulcer in Italy as opposed to the United States, where that patient may just be admitted to coordinate those services as opposed to having a critical digital ischemia. And so that's hard as a patient because you're trying to read and you're trying to get information and you're trying to understand, how do I best treat this? And it's very different across different countries. So the main challenges when we think about Raynaud's phenomenon is that oftentimes patients are not receiving background therapy for Raynaud's. And so if a patient doesn't have a significant amount of pain or discomfort with Raynaud's, oftentimes they will not be on therapy. And I think that's a really important take-home message from this talk today, is that actually anyone with Raynaud's should be on therapy, because by stabilizing that blood vessel, we may be able to prevent digital ulcers. And when you're reading about different treatments and things tried, I think it's very difficult to come to consensus because there's many different study lengths for Raynaud's or digital ulcer clinical trials. And this is often determined by a budget rather than science. So oftentimes how long that study is determined by the people that design the studies and not based on hard, fast literature. It comes into this concept of powering a study. So before you do a clinical trial, there has to be a certain number of patients in that study. And then one of the issues that comes up, particularly with Raynaud's phenomenon and digital ulcers, is oftentimes you want to put patients into the study that you think will have the most short-term benefit in response to that treatment. Well, as you all know, Raynaud's can be very different amongst patients. The episode length, how the patient experiences that is very different. And so unlike interstitial lung disease trials that really focus perhaps on the first 7 years of disease or patients with a certain autoantibody, like the SEL70 that we know may get more in the way of interstitial lung disease, we have a really hard time powering studies for Raynaud's phenomenon. And then importantly, we don't really do a very good job knowing how to define the endpoints for scleroderma, Raynaud's phenomenon, digital ulcer. And particularly for the FDA, we've spent lots of time on this, is the only way you can get a drug approved is if you're able to capture the construct of how a patient's feeling, functioning, or surviving. And if you don't have good outcome measures that you can capture these constructs, then the FDA will just say, well, the drug wasn't proven to work. All this to say is lots have been tried for Raynaud's phenomenon and digital ulcer trials. And so I'm showing you the last 40 years of different trials and different drugs that have been tried for either Raynaud's or digital ulcers. And I put a star if it was a positive trial and a star and a caret if there's conflicting data on different trials, and then there's nothing if it was a negative trial. And what really, if you might be a little bit discouraged by looking at this and say, well, gosh, lots have been tried and we have nothing that's FDA approved. I think there's two important points to make, is that as time has gone on, and this is pretty exciting, I think in the last few years, we've really increased the rigor of how we're designing trials and how we're validating the results. So this means that we're getting closer and closer to having drugs to use for Raynaud's phenomenon digital ulcers. And there's a lot of exciting drugs coming down the pipeline. And we're also having a lot more global representations of scleroderma patients. And that's particularly important in folks that have different types of autoantibodies. So RNA polymerase 3 is a lot more common in North America and rarer in Asia. So we really want to have larger studies done with lots of different types of patients to understand which treatments make sense. And one of the areas of focus that I work a lot with collaboratively is try to figure out how do we get these 4 standard drugs to our patients in the US and have the FDA say, yep, we're going to approve these, or insurance companies now have to cover the cost of these drugs. And so the first line treatment for Raynaud's are calcium channel blockers. So that's your amlodipine or nifedipine. And these are not FDA approved, but they're cheap, so they're easy to get. The 2 main side effects of these drugs that limit our up titration are worsening heartburn. So you may notice that as you're using higher doses of the calcium channel blocker, you're requiring more reflux medications, and it can cause quite a bit of lower extremity swelling. So if you're going to really up titrate that dose, it's really important to have compression hose on in the lower extremity so you don't get too puffy. The next line, generally speaking, is phosphodiesterase inhibitors. That's sildenafil or tadalafil. Those 2 drugs are more expensive, but we have to use some workarounds in the US and not use your insurance company and use different ways to get it. They are first line drugs if you have a digital ulcer. So calcium channel blockers, first line for Raynaud's phenomenon, phosphodiesterase inhibitors, first line for a digital ulcer. And then the endothelin receptor antagonists, so that's the bosentan, macitentan, those drugs are usually restricted in the US purposes for pulmonary arterial hypertension. There has been work on bosentan that said if you have an ulcer or lots of ulcers, if you start an endothelin receptor antagonist, you may get less new ulcers. And so there are ways to get these drugs, but they're harder to get access to. And then lastly, prostacyclin analogs, that epoprostenol, iloprost, those drugs are quite expensive and difficult to get for this indication, though are recommended on the guidelines in Europe. So if we were to compare studies from around the world, in Canada, if you're looking at the Canadian Scleroderma Research Group's publications, most of the time the access is only to calcium channel blockers and the phosphodiesterase inhibitors. Looking at the UK and in Europe, you can get all the different drugs available. And so that's why our guideline-based practices include all of these different drug options. And then in Japan, for digital ulcers, they've done a lot of the work for endothelin receptor antagonists and prostacyclin analogs for digital ulcers. And so when you look at the Australian group, you can sort of, and look what's available to you. That gives you a little bit of the context of why all the recommendations are sort of all over the place when you look across the globe, and why different outcomes are different or more prevalent in different countries. But all that to say, what we're really quite passionate in is successfully shortening the process of getting therapeutics to our patients faster. And the way we're doing this is we are working with collaborative research groups or cohort studies where patients who are prescribed a medication go into a registry, and then we can compare these patients longitudinally. So even if they're paying out of pocket, if we're at 18 different centers in the United States, we're gathering this data. And the reason it's important is we have asked our Australian colleagues in the Australian Scleroderma Interest Group to join us and to collaborate on this important project. And I put that out there because it's your data, or how you're feeling, how you're functioning is really important for moving the field forward. So registries are really very beneficial in getting our drugs approved, and so that we can study them more properly. So one of the first thing that's really important is to make sure that the symptoms you're having is actually due to Raynaud's phenomenon. And one of the things I always teach my fellows or trainees is to actually show a picture of Raynaud's phenomenon. And the reason that is so important is there's a lot of things that can cause tingling or numbness or burning in the hands that are not Raynaud's phenomenon. And why that's so important is if you're pushing vasodilators for tingling that's not related to Raynaud's, it's not going to work. So one of the things we really tell folks is that it's important that if you're experiencing a symptom, that you know it's Raynaud's, if it's sensitive to the cold, and even if you just have a 2-phase color change, that should be triggered by cold emotional stress, and it usually should be bilateral, and you should see this demarcation line. And why, again, that is so important is can be, and I'm sure there are going to be people who shake their head on the call and say, oh yeah, I had that, is you can have Raynaud's phenomenon and then also something else. And so in my patient population, if their symptoms are worse unilaterally or positionally, so when you turn your neck towards that little purple spot here, and you start to get tingling and pain in the hand here, or if your doctor's feeling the pulse here and moves the arm back and that makes the symptoms come more severe, it could be that actually it's this nerve bundle that's being compressed either under the bone, under tight muscles or tight skin, or you could actually even be hyperreflexive. So you move it and you're actually compressing it because your bones move too well. So because these different causes of this symptom will not respond with vasodilators, it's really important that we think about this as being a contributor to your symptomatology. Other things that won't get better, and this is particularly important for our veterans. So I actually just came from the VA clinic. It's nighttime here. So I just had a full day of seeing our veterans, and it's very common for particularly our military population to have been deployed without adequate gloves. And so if you've had frostbite or you have a lot of vibration and in your line of employment, what can happen is you can get kind of permanent tingling, numbness, and burning. And so the good news is this doesn't get worse. It doesn't cause worsening capillaroscopy changes, but a scleroderma patient that does a lot of vibratory work or has had frostbite, this, no matter how many vasodilators we give, will not get better. Tobacco and drug use do matter. So I always really lean on my patients to stop smoking. And then you really want to ask about stimulants and other drugs. And so most of our bad actors, and this is what it gets really quite tricky, is scleroderma certainly causes fatigue, and Sjogren's, which is one of the common overlaps of scleroderma, causes fatigue. So stimulant medications are commonly given to kind of help people have a little bit more energy. And these drugs actually do cause nail fold changes. So they really are like little whips to the smallest blood vessels in the body, and they can cause damage to the blood vessels. So I really try to tell folks, watch what medications you're taking. And one of the first steps, if you have scleroderma, is reviewing your med list with your provider and making sure that you're not on something that could potentially be making your Raynaud's worse, such as a beta blocker. And that can be used for essential tremors or for blood pressure for heart disease. Hypothyroidism and carpal tunnel also can make those hand symptoms worse. And so having your thyroid checked once a year and being assessed for carpal tunnel, which I'll show you in the next slide, is important. I actually just saw a patient today whose Raynaud's is way better now that they've had their carpal tunnel released. So again, you can have two things, and it's important to think about that. One of the things that can help you and educate your doctor is inspection of your own hand. So I really encourage my patients to be advocates for themselves. Sometimes you'll know a lot more than the healthcare provider assessing you. It's a rare disease, and that's unfortunate, but it's true. Now, I think that's why you're all here today, is to learn about how you can advocate for yourself. And I think it's a critically important mission of our community. So the first thing you want to look for is swelling or puffiness of your hands. And I like patients to get the puffiness out of their hands, so I use a lot of compression gloves. You can see an occupational therapist and learn kind of manual massage and swelling management. And just remember, a lot of your drugs can cause you to be puffy. So again, really review that med list with your physician and make sure we're not giving you something that's going to make you more puffy. Skin tightening, there's been lots of good work looking that patients are very good at assessing if their skin is changing. So if you feel like your skin is more tight and itching, that can be a disease activity, or red. So you're really going to want to communicate that back to your provider. Say, I think my skin is changing. The reason that's so important is that is an indication for immunosuppression. So for most digital vascular problems, we're going to give you vasodilators to treat this. But if the skin's starting to, this actual skin is tighter, an immunosuppressant is indicated. The doctor should always look for telangiectasias on your fingers and around your lips. But you're your own advocate, so make sure you're looking at your hands and around your lips. If you're getting more in the way of telangiectasias, that has been associated with the onset of pulmonary arterial hypertension. So lots of new red spots on your fingers should prompt you to talk to your doctor and to make sure that your annual echocardiogram is up to date. Pits on your fingers and digital ulcers, cracks, all of those I really love wound care for. Actually, I used to have all my patients import from Australia Manuka honey because we couldn't get it. And so that's really good for pits. So you can use that pretty liberally, and it has a lot of good antibiotic properties. And then lastly, nail fold abnormalities. And this has been, I think, kind of fun for the advances in the iPhone, is you can look at the base of your finger, and I'll show you, to see if you notice any changes. And that becomes important for us knowing how well we're doing with your vasodilation. So what does a vascular exam look like? So one of the things your doctor will do is start by just examining the hand. They can have you make a fist, and they'll press both sides of the vessel. And then what they'll do is they'll, when you release your palm, it should be nice and white or pale here, because you're not getting blood flow when it's pressed. And then when they release, it should pink up within 5 seconds, and that's called an Allen's test. So they'll feel both of the ulnar pulses, and they'll do that Allen's test just to make sure your macro circulation is there. So what is macro circulation? Those are the big blood vessels, and the vasodilators we give act on the smooth muscles of those arteries to get you good blood flow to your finger. The next thing I like to do is just compress on the median nerve. That kind of reproduces carpal tunnel. It's not perfect, but if that's causing all the numbness in your hands, irrespective of Raynaud's, that's something that will either do an EMG nerve conduction study or an ultrasound, and you can really benefit from splinting to offload that, or injections, or if it's quite severe, a surgery can really help. And the reason that's so important is if you have bad carpal tunnel that's untreated, and the nerves get damaged, those don't get better. So you want to kind of catch this early and have that procedure done to make sure that you get improvement in your hands. Unfortunately, the contrary is oftentimes true. Patients will say, the doctor didn't find my Raynaud's. They sent me to carpal tunnel surgery. I got carpal tunnel surgery and it didn't help. And so unfortunately, oftentimes you've already had surgery by the time patient or doctors are figuring out that the numbness is related to Raynaud's. And then this last part, which I said I really think is important, is this examination of the nail fold. And what you can do is just put KY jellies on the nail fold. You're getting rid of the dry skin. Cuticle oil or olive oil will work too. And you're just looking at the base to see if these red blood vessels pop up. And lastly, being active about counting your digital ulcers and pits become important again, because if we're doing a good job with your fingers, the nail fold should stabilize and the number of pits and ulcers should improve. So what's capillaroscopy? So capillaroscopy is putting that oil on the base of the nail fold, and then your doctor's looking under magnification at this last loop of your nail folds. And so this is what it looks like. I have a little device I carry around in my pocket. I connect that to my iPhone just to show patients. And then what you're doing is you're counting the number of capillaries in this 1 millimeter last row. And you're looking at this apical diameter, and you're saying, is it dilated or giant? And so that can be diagnostic for scleroderma. But what's really helpful is if you do this over time, you're able to look at the different shapes and see if they're changing. And the most important thing is if you're starting to lose blood vessels, that's associated with digital ulcer. So how I use this in clinical practice, I use it to diagnose a patient. But then what I also do is I do it in clinic at the follow-up visit. And if I start to notice blood vessels dropping out of this last row, I really want to push my vasodilation. And there's lots of different ways to do this. This is like one of the most common questions is like, my doctor doesn't have one of these kind of fancy devices. How can I do this longitudinally? So you can even use your smartphone that gets to about 60 times magnification, and that's actually good enough for normal versus abnormal. So I always say to the physicians I train, it's not good enough just to say I didn't look. Everybody has a smartphone and you can use that. A dermatoscope, which you can maybe even see in my background here. I keep that pretty handy. It can be a pretty cheap device or a more expensive, and that gets you some information. What's kind of the newer kid on the block is this USB microscope. It's kind of it's a lot cheaper, and it gives you a lot of different diagnostic information, and it is mentioned at the training courses. But the gold standard are these sort of fancy devices that allow you to record the change over time and really quantify things. And the way we do it here at Vanderbilt is we do a super cheap screen. I have all the fellows just connect this to their iPhone and get a little bit of a quick look at what the nail fold looks like. We publish that is good enough. This is blurry, but for your case and purposes, just to say within about 5 minutes, you can say whether you think a patient has a normal scleroderma or a normal nail fold pattern, a scleroderma pattern, or some abnormal features. And if there's abnormal features, our standard of care is to generate a report, and that gives us all this quantified information over time. We then have patients fill out patient-reported outcomes. We have a low threshold to get hand radiographs or x-rays, and that actually can give you a lot of information. Acrosteolysis is where the tip of the finger goes away. Calcinosis is where these calcium deposits go on your finger. And these can drain and they get mistreated as infections. So I oftentimes, first visit, we'll just say, let's get baseline hand radiographs so we know what we're dealing with for the hand. Because the goal is we want to improve symptoms and prevent digital complications for our patients. So again, where you might have historically thought, well, Raynaud's is just sort of symptom-based, I really firmly believe it's critical to treat this part of the disease. And if we do it well, we might prevent other complications. And this kind of idea of really being passionate about good hand care for patients came from an early project I did, where we looked at a Vito's population, so very early diagnosis scleroderma, so patients that had Raynaud's, puffy hands, a scleroderma-specific autoantibody, and nail fold changes. We said, these patients all look the same in clinic, so we then looked at all the different inflammatory molecules that could possibly be involved in scleroderma and that you could target therapies for. And we did this in conjunction with a pretty famous lab in the US that was developing cytokine or cellular stress signal profiles. And we said, well, let's just see what's causing this. And you can see when you look at two different patients, perhaps why we don't have drug treatment for scleroderma is we had some patients with no inflammation and other patients with lots of inflammation. And so when we look at these different panels, you can imagine this patient may respond to anything that we use for that targets the immune system, where this patient, nothing would work. And so we really thought, well, if that's the case, if immunosuppression is not as effective, do vasodilators actually prevent complications? What we really want to understand is how do we best measure low blood flow and oxygen delivery that's causing vascular leak or puffiness in the clinic? And in particularly, how do we understand what's the role of our arteries, our capillaries, our veins, our lymphatic system? How do we really study that well in clinic? Because our goal is that if stress caught in the blood vessel and growth factors in the immune system are all involved, can we prevent that by understanding the blood vessel? So my clinical research goal was I wanted to directly measure in the clinic different vascular parameters that could guide my treatment. And so I'm going to go over in about 2 slides, about 15 years worth of work. But I didn't want to bore you with the science, but I think it's a pretty interesting story. So I think you should know where the science comes behind. So the endothelial cell, that is your blood vessel lining cell. And we found that it universally in scleroderma has an abnormal shape and it functions abnormally. And the way we thought through this is we started with the Utah population database. And so the Utah population database takes the medical records of over 7 million families or people that have families that are linked to the Mormon or the Latter-day Saints Church genealogy records. So these genealogy records go back 11 generations. And then what you can do is you can look in the medical records and say, I want to find a patient with scleroderma. And then I want to see how they are related to other patients with scleroderma. And then I'm going to compare that family to another family that has the same structure, so the same number of generations, but has no scleroderma. And what I want to do is see if all of those patients in this Utah population database have scleroderma, how many people in those families compared to other families without scleroderma have Raynaud's phenomenon, other autoimmune diseases like lupus or inflammatory myositis or interstitial lung disease. And if we operate with the thought process, you are born with your genetics, so you're born with your risks for disease, and then something might trigger that disease, and then that propagates the disease. Can we understand those genetic risk factors before the disease occurs to really get at what can we do for prevention? So that's kind of the concept of looking at familiar genetic traits. So when we did this study, what we found is that for Raynaud's phenomenon, out of all the different things we looked at, a first-degree relative was 6 times more likely to have Raynaud's phenomenon if they were in these families with scleroderma than compared to the families without scleroderma. And so we really felt that was Raynaud's is a really important trait in families. So maybe that's what we should really be focusing on if we really want to think about how to understand this disease. So then we went, and I had told you when I started, we had this really fast track of looking at patients. So patients that just had Raynaud's, we were looking at, and then we were looking at patients that had scleroderma. And when we looked at patients with Raynaud's phenomenon without scleroderma, and we did skin biopsies, the endothelial cell, so that vascular lining cell in the Raynaud's phenomenon patients was normal. So didn't have any stress or cellular abnormalities. But in patients that had Raynaud's and scleroderma, we start to see this endothelial cell or vascular lining cell swollen. He's sending out little stress messages. He's got a duplicated basement membrane. And as you would expect, patients that had longer disease duration, their cells had more stress and had more scarring around them that actually started to make the endothelial cell not look healthy at all. So if you had 6 months disease duration or 36 years disease duration, all of the endothelial cells were abnormal, and the longer disease duration had the most abnormalities. And you might say, well, okay, that doesn't, if you're born with this and there's nothing you can do, that seems kind of like, you know, what's the next step? But we asked the question, we said, well, maybe it's abnormally shaped, but if it's functionally, we can make it act better if we give the right drugs. So in order to understand why does this cell look like this and why does it not work very well, we did human subjects experiments where we did all these different experiments of measuring blood flow. You can occlude the blood vessel, you can make people exercise, you can give pharmaceutical interventions, but you're measuring how well blood goes through the brachial artery or the femoral artery, how well it responds to occlusion or stress. And when we did that, we found that scleroderma patients exhibited evidence of elevated oxidative stress and attenuated antioxidant capacity at baseline. So that meant that their cells seemed to be under a lot of cellular stress. And that would make sense if you think about when you have vasospasm, you're not getting good oxygen delivery to the finger, and that's going to send out a cellular stress response. We also found that patients that had low blood flow and weren't able to respond to different experimental stresses were more prone to develop digital ulcers. So that really told us, gosh, we can't just be waiting for someone to have Raynaud's and then get a digital ulcer and then care and treat. We better be getting good blood flow to the hands and trying to address this early on. And we really showed that actually, if you got patients exercising or we were able to reduce the oxidative stress, those blood vessels looked a lot more like healthy controls. And so that gave us this excitement that actually this is a reversible lesion and we just need to be better about understanding treatment. And that really got us to thinking, well, what does a blood vessel do under normal conditions? And how can we change the scleroderma endothelial cell that kind of has this blunted appearance to the luminal cell lining, and has these cellular stresses. This autophagism is like a help signal. Help, I'm either starving or I'm not getting enough oxygen. How do we make all this cellular machinery work better and look more like a happy, healthy endothelial cell? And what we were really interested in, if blood flow goes through your blood vessel and it comes up against this glycocalyx, this sugar lining of the endothelial cell, how do we make that function better? So then the natural vasodilators that we're giving you medications for would work better. And so we did lots of sort of understanding of how blood vessels work. And the way we did this was twofold. We did serial nail fold capillaroscopy. So we're measuring, like we talked about before, what are those blood vessels doing? Are they dilating? Are you getting little hemorrhages? Are you getting scarring and funny growths? And we measured it both on the nail fold and then underneath the tongue, because we were very interested in certain patients seem to get this thick frenulum. So if you lift your tongue up in the mirror and take a look, this fibrotic change was occurring in the vasculature underneath the tongue. And so we decided we would use this probe underneath the tongue, and we would measure blood flow. And we would say, how well are all the little blood vessels getting filled with red blood cells? And again, the red blood cells are what delivering oxygen. And then we got an estimate with this software that gave these little cuts and told us how healthy is that endothelial cell. And that allowed us to compare scleroderma patients to healthy controls. And we said, well, goodness gracious, all of our scleroderma patients have at every different blood vessel segment, so the tiniest little blood vessels versus the larger, all of the blood vessels seem to not have as much vascular health compared to our healthy controls. And that correlated between both the nail folds and underneath the tongue. And so that really tells us, we tend to think of digital vasculopathy, but maybe that's just because we can see it. We don't have a better understanding of the blood vessels in other parts of the body, but we sure should be thinking about vascular health throughout the body. So what we decided to do is we thought, well, we better model, and this is the last kind of science slide, so bear with me. We said, this is what should we do to study scleroderma? If we really want to prevent ulcers, we need a better model. We can't just look and wait until someone's sick and then react. Could we understand if you're not getting good blood flow, so we call that ischemia reperfusion. If you're not getting good blood flow, and that's setting up autoimmunity and activating the immune system and causing these cells to be unhappy and die and really kind of leak fluid, so we see the Raynaud's and then puffy fingers and on hardness, how can we best model that? And so what we did is we decided, well, what if we take blood cells from a patient and we reprogram them into an endothelial cell. And then we can compare those endothelial lining cells between a healthy patient and a scleroderma patient. We can test them. So we can look at genetics, we can functionally test them and understand, is there something in these scleroderma cells that is abnormal that allows us to treat it? And we did this successfully. And at baseline in a small percentage of patients, so I don't want to oversell this. This was a research grant. So we took a look at scleroderma patients and healthy control patients, and we saw that oxidative stress just in these cells that all looked healthy and perfectly fine, that in our scleroderma patients, oxidative stress genes were really upregulated. And then we also noticed that those patients had these differential expressions of proteins and genes that really said, I am under stress. And so what we really propose to do is say, okay, these cells are so stressed out with oxidative stress. Would antioxidants or would a healthy diet help improve this gene expression profile? And that really brings us to wounds. So I know why I was invited to talk, but I had to give you that whole backstory because all wounds are not created equal. So you can have patients that have these traumatic ulcers, so that just you hit your finger, and I know people here on the call are like shaking their head, yes, this is terribly painful. And it's because the skin is so tight and there's so much scar tissue that the blood vessels are not growing in or delivering growth factors. And so we did lots of try to understand, can we get hyperbaric oxygen? Can we deliver oxygen to these tissues better? We also realized that when you have compression lesions, like under a nail fold, those really don't get good oxygen. So we did quite a bit of work with wound care of trimming nails away. And oftentimes you've been probably told, oh, if you get an ulcer, just leave it well enough alone. And that was really because rheumatologists were not very well trained in wound care. So we leave it well enough alone because we don't know what to do. And instead, working closely with wound centers for hyperbaric oxygen or trimming the nail away can be very helpful. And then it turns out if you have an infection, all the vasodilators in the world won't help. And so oftentimes trying to do wound cultures to see if there is infection present. And so we use what's called a time algorithm. So we use the wound care to tell us, do we have to remove the devitalized tissue? And that's particularly important if you have a calcinosis lesion. Your body thinks that's like shrapnel. It's the infection fighting cells are trying to push that out. So it's really very inflammatory and painful. And so really getting in and numbing that up and getting that calcinosis scraped off can be helpful. Treating the infection like we talked about. And then this is very tricky. So how much moisture you want to put into a wound? So do you keep it dry to dry it out like in this ulceration? Or how do you prevent getting those skin cells to grow in? And so to do this, we worked with our regenerative medicine team to use these amniotic membranes. So these amniotic membranes, what happens when a woman gives birth, she can donate her amniotic membrane to a research laboratory. And what they did is they sterilized it, they scraped off all the growth factors, and they made these bandages. And what became sort of problematic is for a short period of time in the US, the FDA really wanted to get burn and frostbite care to patients faster. So they sort of let the regulation of these products kind of go. And so about hundreds of products sort of flooded the market. And it was somewhat problematic because they were not very well regulated. And so you can get amniotic membranes, but they also have synthetic growth factor membranes. And what that does is it puts all the growth factors, all the things that would relieve that oxidative stress of that wound, and you put it right onto the wound, and it does a really beautiful job healing. And we actually published this because it actually was so incredibly soothing to our patients. We wanted to get the message out is these are really effective for pain relief and healing. And so one of the things to ask at your wound care center is, do you have amniotic dressings or growth factor dressings? And if they say no, or I've never heard of this, they're used commonly in burn centers or frostbite. And I know in Australia, you don't have a lot of frostbite, but in Utah, we had a lot of frostbite, so I could get a lot of these dressings. So it's something to know about. Other things to know about, there's a new questionnaire called the ASRAP, or the Assessment of Scleroderma Raynaud's Questionnaire. And this goes over the past 7 days. There's 10 questions, and it allows your physician to track this over time. So it's been published, and we published this a couple of years ago, and I played a really important role for gathering lots of patients into this study because it's the first questionnaire that's ever based on the patient experience. So this is really, I think, a pivotal change in our field. So prior to this time, we used the Raynaud's Condition Score, which doctors thought patients should use. It wasn't based on what the patient told the doctor. These are the important questions I want to be asked. So we started this process many years ago. Dr. Pauling, who created this questionnaire, he actually flew out to Utah, interviewed a lot of my patients. He flew out to Pittsburgh. These are patients from mostly the UK and the US, but we did all these focus groups and had all these expert level statisticians involved. But this questionnaire really captures the patient's voice. And what's really cool about this is now we can quantify therapeutic response. So we can maybe start to get drugs to our patients because we have a way to capture the outcome. That's why I belabored at the beginning, like, we don't have anything because we did this all wrong in the past. But now we're really starting to get more data. This is another really cool study that I think is worth knowing about. So we do a lot of thermography, and you might, I know that a lot of the investigators in Australia do this as well. But one of the things we're really trying to study is regional blood flow. In the way I told you at first, if you give too much blood flow to the finger, you can actually make things worse because it compresses the blood flow. So when I told you the kind of holy grail here is trying to understand the sweet spot of blood flow to the fingers and controlling the edema. So we were using a lot of regional calculations to understand what drugs give you actually too much blood flow. And that may be why In big drug trials, we say things don't work. Well, if we're up titrating the response of the drug without a proper patient-reported outcome, you can imagine that we're not really doing this very well. So there's been a big shift in the field understanding how to get the right amount of blood flow. And then something really cool that we've proposed to do at Vanderbilt is we're using this camera, which looks at blood, how well the infection fighting cell count pauses at the blood vessel wall and extravagates and goes through. And so what we're trying to really do is quantify if a blood vessel doesn't work so well, and we can make it work better with vasodilators, that's great. The blood vessel doesn't work so well, and that's making your infection fighting cell count or infection fighting cells stick to the blood vessel, go to the other side and start laying down scar tissue. That is also something we want to quantify. So all this to say, there's a big push in the field for particularly understanding prevention and treatment of wounds and how we can better understand the immune system in that setting. So I will sort of wrap up that research part to say, you might say, okay, what I really want to know is if my blood vessel lining cells don't really respond well to stress or damage, what can I do to prevent this? Because it's not good enough to say, oh, all this fancy stuff is coming down the pipeline to study this better. And so the real take-home message here is you want the right amount of vasodilators, the right amount of wound care, and your comprehensive team. So with rheumatology and dermatology, one of the things we really have done is try to understand exercise response to wounds. And that is fascinating, that more than any vasodilator in our registry, it was our patients that were exercising that had the best vascular outcomes. And if you think about it, that makes sense. We're trying to study laboriously how to get the right amount of blood flow to your fingers. Well, the one thing that trains your blood vessels to vasodilate naturally is exercise. So it turns out, and this is one of my dear patients who gave me permission to use this, so even with fixed contractures, if you can get moving and trying to build your muscle strength, your ulcers will do much better. So we really push a good, solid exercise program for all scleroderma patients. And that shouldn't be limited if you have interstitial lung disease or you're on oxygen. Pulmonary rehabilitation programs can do exercise in a safe way. With gastroenterology, we really wanted to work more with nutrition. So I'm not into supplements because I don't think they've been studied well enough to say, oh, try this antioxidant or try to take this pill. But if you look at green is good and fresh is best, the highest amount of antioxidants in our diet is with healthy food. So I really push trying to figure out healthy for you and using a nutritionist to get to an antioxidant state. And I will tell you, if you're tracking your GI tract symptoms and you're eating healthy for you, when your symptoms get better, your wounds get better. And that's been reported in literature for a long time. We know people with more wounds have worse GI tract symptoms. So really trying to use nutrition to navigate your GI tract symptoms as well as your wounds is important. And then lastly, like I started with, I really love wound care specialists, occupational therapists. They really are the cornerstone of my care program. I work with a man named Justin Steer, who's an occupational therapist, who sends me articles on scleroderma. He's so active for trying to understand the best wound care for our patients. And I just think it's a blessing to work with a great care team. And so I just wanted to conclude by saying, collaboration and precise clinical phenotyping is really critical for discovery. So not all scleroderma patients have the same outcomes. But if we studied all scleroderma patients in the same way, that's how we make discovery. And so what I started with was just a really dedicated scleroderma program. And I was very keen again on that early diagnosis and doing lots of screening and trying therapeutic interventions because I had this goal. I'm going to treat this disease well, so maybe I prevent some of the disease progression. But what I really found is if we also study concurrently very established scleroderma patients and we understand the difference between disease activity and damage, and the Australian researchers have been pivotal in the field. Laura Ross, Mandy Nickapor, Wendy Stevens, these fantastic physicians have really taught us how to do this well, and we've integrated a lot of the things that they've taught us in the US. And on our collaborative research program, what we really try to do is make sure every patient is treated as an individual, but every data element is put in our database. So in summary, I hope I've convinced you to join longitudinal registries. So it's really important that all of your data, particularly how you're feeling and functioning, is captured, and that we really want to globally work together so that we understand how to do clinical trials better. I'm really excited because we have so many good things coming down the pipeline for treatment of digital ulcers and wounds. And then lastly, I really want to highlight that it is a journey together. My greatest honor is to be part of your community. Really working for optimized patient management is quite a joy. And I'm happy to open it up for discussion, but want to recognize the many patients that really help us with fundraising to get us the money for research. This is the Scleroderma research team from Utah that did all the human subject experiments. This is a conference I hosted this summer in Nashville. Here's our AT&T tower. From around the world, we had people come in to learn nail full capthoroscopy, and we're integrating this into the research collaborative efforts here in the US. And then I have funding sources that you can't do the work without money, so I always like to thank them for allowing me to be a part of this community for the last 20 years. And with that, I am going to stop screen sharing so I can see the questions and see your lovely faces. And let's go. All right.
That was fantastic, Tracy. Thank you so much. Very informative and so interesting